A warm welcome to the medical and paramedical students and my dear colleagues. In this episode, we will be discussing hernia. The part 1 will cover anatomy, classification, features, history taking, types, causes, investigations, differential diagnosis, and differences between the direct and indirect hernia. A hernia is defined as an abnormal protrusion of an organ or a tissue through an opening in the layer of its containing cavity. A hernia has got the following parts: mouth, which is the defect in the abdominal wall through which the hernia originates; neck, which is the smallest part of hernia sac, most likely to cause complications; body, which is the widest part of hernia; fundus, which is the distalmost part of hernia; and contents, which might be omentum or intestine or both. The anatomy of inguinal canal is as follows. The inguinal canal is a 4 to 6 centimeter long cone-shaped structure located in the inferior part of anterior abdominal wall. The inguinal canal is covered by skin, subcutaneous tissue, which is superficial fatty Camper's fascia and deep membranous Scarpa's fascia, and the external oblique aponeurosis. The canal runs obliquely from the deep inguinal ring to the superficial inguinal ring, above and parallel to the inguinal ligament. The deep ring is a U-shaped defect in the transversalis fascia 2 cm above the midpoint of inguinal ligament between the anterior superior iliac spine and pubic tubercle. The superficial ring is a triangular defect in the external oblique aponeurosis 2 cm above and medial to the pubic tubercle. The boundaries of inguinal canal are: roof is formed by the conjoint tendon, posterior wall is formed by the transversalis fascia, floor is formed by the inguinal or Paupart's ligament, and the anterior wall is formed by the external oblique aponeurosis. The nerves in relation to the inguinal canal are: number 1 is the ilioinguinal nerve. It arises from L1. It pierces transverse and internal oblique muscle above the anterior superior iliac spine to enter the inguinal canal and exits through the superficial inguinal ring. It supplies the superior medial part of thigh, root of penis, and upper part of scrotum. Number 2 is iliohypogastric nerve. It arises from T12 and L1 nerves. It pierces transverse abdominis muscle and runs below the internal oblique muscle and supplies both these muscles. It divides into lateral cutaneous branch, which supplies the superolateral gluteal region, and the anterior cutaneous branch, which supplies the suprapubic skin. Number 3 is genitofemoral nerve. It arises from L1 and L2. The genital branch enters the deep inguinal ring along with the spermatic cord. It supplies scrotum and cremasteric muscle. And the femoral branch runs behind the inguinal ligament, enters the femoral sheath lateral to the femoral artery, and supplies the anterior and superior part of thigh. The contents of inguinal canal are: ilioinguinal, iliohypogastric, and the genital branch of the genitofemoral nerve, spermatic cord in males, round ligament in females, and lymphatics. The contents of spermatic cord are: external spermatic fascia, which arises from the external oblique aponeurosis; cremaster muscle fibers, which arise from the internal oblique muscle; internal spermatic fascia, which arises from the transversalis fascia; vas deferens, artery and vein to the vas; cremasteric artery and vein; genital branch of the genitofemoral nerve; pampiniform plexus, processus vaginalis, lymphatics, and fat. The boundaries of Hesselbach's triangle are: laterally is formed by the inferior epigastric vessels, medially is formed by the lateral edge of rectus abdominis muscle, inferiorly is formed by the inguinal ligament, and floor is transversalis fascia and is bisected by the medial umbilical ligament. There are 5 peritoneal folds, one is unpaired and 2 are paired in the inferior part of anterior abdominal wall, which converge at the umbilicus and which gives rise to 3 fossae. Number 1 is median umbilical ligament, which is a peritoneal fold raised by the obliterated urachus. Number 2 is supravesical fossa, which lies between the median and the medial umbilical ligament. Number 3 is medial umbilical ligament, which are paired and formed by the peritoneal folds raised by obliterated umbilical arteries. Number 4 is medial fossa, which lies between the medial and lateral umbilical ligament. Direct hernia arises in this fossa. Number 5 are the lateral umbilical ligaments, which are paired and are peritoneal folds raised by inferior epigastric vessels. And number 6 is the lateral fossa, which lies lateral to lateral umbilical ligament. Indirect hernia arises in this fossa. The preperitoneal spaces are: number 1 is the space of Retzius. It is a preperitoneal retropubic space bounded by anteriorly the pubic bone and superficial transversalis fascia, posteriorly by the urinary bladder, superiorly by the umbilicus, inferiorly by the pelvic floor muscles, and laterally by the inferior epigastric vessels. Number 2 is the space of Bogorodius. It is a lateral extraperitoneal space bounded by anteriorly the superficial transversalis fascia, posteriorly the psoas muscle, external iliac vessels and femoral nerve, medially the inferior epigastric vessels, and laterally the pelvic wall. Number 3 is myopectineal orifice or Frouchard. It is an area bounded by superiorly the conjoint tendon, inferiorly the pecten pubis, medially the rectus sheath, laterally the iliopsoas. This space is divided by the inguinal ligament and is the site of all groin hernias. There are 4 anatomical causes of hernia development. Number 1 is congenital developmental anomalies of abdominal wall, like that of diaphragmatic hernia. Number 2 is traumatic disruption of the abdominal wall, like that of incisional hernia. Number 3 is natural openings in the abdominal wall that allow structures to enter or leave the abdomen, example inguinal hernia or femoral hernia. And number 4 is natural weakness in abdominal wall due to the absence of muscular covering, like that of a lumbar hernia. The causative factors for hernia are chronic cough, chronic obstructive pulmonary disease, chronic smoking, straining like that occurs in benign prostatic hyperplasia or constipation, heavy weightlifting and physical exertion, ascites, pregnancy, family history of hernia, connective tissue disorder, obesity or previous abdominal incision. The European Hernia Society classifies groin hernia as lateral inguinal, medial inguinal or femoral hernia denoted as L, M or F, primary or recurrent denoted as P or R, and depending on the hernia defect size, less than 1.5 cm, 1.5 to 4.5 cm and more than 4.5 cm. The Nyhu's classification of inguinal hernia is type 1 indirect inguinal hernia in which the deep inguinal ring is normal, type 2 indirect inguinal hernia in which the deep ring is dilated but the posterior inguinal wall is intact, inferior deep epigastric vessels are not displaced. Type 3 consists of posterior wall defect which gives rise to direct inguinal hernia, indirect inguinal hernia in which the deep inguinal ring is dilated and the inferior deep epigastric vessels are displaced, and femoral hernia. Type 4 consists of recurrent hernia which might be direct, indirect, femoral or combined. The Gilbert classification of hernia is type 1 indirect hernia with a small defect of size less than 1.5 cm, type 2 indirect hernia with medium defect of size 1.5 to 4 cm, type 3 indirect hernia with a large defect of more than 4 cm, type 4 is direct hernia in which there is an entire floor defect, type 5 direct hernia with diverticular defect of the floor, type 6 is indirect hernia with a direct hernia which is also called as pantaloon hernia, and type 7 is femoral hernia. The Schumpelick classification of hernia is L is lateral or indirect hernia, M is medial or direct hernia, MC is combined or pantaloon hernia, F is femoral hernia. Depending on the orifice size, type 1 is hernia orifice less than 1.5 cm, type 2 is hernia orifice of 1.5 to 3 cm, and type 3 is hernia orifice more than 3 cm. The following complaints may be present in a patient with hernia. The most important and the most common complaint is the lump. It is usually noticed by patients after coughing or lifting heavy weights. If it appears in groin and then involves the scrotum, it is usually an indirect inguinal hernia. If it appears below the groin and spreads upwards, it is usually a femoral hernia. And a lump of direct hernia usually disappears spontaneously on lying down position. Complaint number 2 might be pain. It is initially associated with dull aching, dragging type of pain which worsens in the evening. Colicky or severe pain suggest a strangulated hernia. Complaint number 3 might be abdominal complaints like that of vomiting, obstipation, abdominal distension and colicky pain, which are features of intestinal obstruction. And patient might have systemic complaints like that of chronic cough, chronic constipation, straining for micturition, etc., which are associated with hernia formation. The following general examination is done in a patient with hernia. Chest examination to look for signs of chronic bronchitis, asthma, chronic obstructive pulmonary disease. Abdominal examination to look for ascites, obesity, intra-abdominal mass. Perectal examination to look for constipation or prostatomegaly. Inspection of a hernia is carried out in the following way. Cuff impulse test, it is a characteristic sign of hernia. Absent cuff impulse may occur if there are adhesions in the neck of the sac, or the hernia is complicated with strangulation, or the swelling is something other than that of a hernia. Location and shape of the swelling is inspected. Direct hernia, which is spherical in shape, occurs above and medial to the pubic tubercle and rarely descends in the scrotum. An indirect hernia is of pyriform shape and it might descend into the scrotum. A femoral hernia is usually spherical in shape and occurs below and lateral to the pubic tubercle. Peristalsis may be visible in thin individuals with bowel as content. Skin over the swelling is inspected. Erythema suggests strangulation of the underlying content. Tone of the lower abdominal wall is checked by head or leg raising test, which is also called as Carnet's test, or by Valsalva maneuver. An oval-shaped Malgagnes bulges may be seen between the anterior superior iliac spine and rectus sheath due to the weakening of the anterior abdominal wall muscles. The following points are noted in palpation of a hernia. Point number 1, temperature. Rest temperature may suggest strangulation of a hernia. Point number 2, tenderness. Presence of tenderness may suggest again a strangulation of a hernia. Point number 3 is size, position and shape of the hernia. An indirect hernia can extend to base of the scrotum and is pyriform in shape. A direct hernia is usually limited to the groin, above and medial to the pubic tubercle and is spherical in shape. A femoral hernia extends upwards above the inguinal ligament, is below and lateral to the pubic tubercle initially and is spherical in shape but might become a retort shape if it extends upwards. Point number 4 is getting above the swelling. It is useful to differentiate between purely scrotal swelling and those of inguinoscrotal swelling. Getting above the swelling by palpating the spermatic cord at the root of the scrotum is possible for purely scrotal swelling but not possible for inguinoscrotal swelling. Consistency. Omentocele is granular and doughy. Enterocele is elastic. Point number 6 is expansile impulse on cuffing. It is a classical sign of uncomplicated hernia. It can be absent in complicated hernia or where the neck of a sac is filled with adhesions. It can be falsely present in saphenous varix and it should always be performed in a standing position. Point number 7 is reducibility. It is the second classical sign of uncomplicated hernia. Hernia may reduce spontaneously on lying down, may be reduced manually by the patient himself or by the physician by flexing, internally rotating and adducting the ipsilateral thigh. Intestine as content reduces with a gurgle with difficult initial part and the latter part reduces easily. Omentum as content reduces easily initially and with difficulty in the latter part due to the formation of adhesions. Point number 8 is Siemens test. An index finger is kept over the deep inguinal ring, middle finger over the superficial inguinal ring and ring finger over the saphenous opening. It is done in supine position once the hernia is reduced completely. An indirect hernia impulse will be felt on the index finger. Direct hernia impulse will be felt on the middle finger and femoral hernia impulse will be felt on the ring finger. Point number 9, finger invagination test. It is done in supine position after reducing the hernia. In direct hernia, cuff impulse is felt at pulp of the finger and finger goes directly backwards through the superficial inguinal ring. In indirect hernia, cuff impulse is felt at tip of the finger and the finger goes upwards and outwards through the superficial inguinal ring. Point number 10 is ring occlusion test, in which pressure over the deep ring occludes the indirect inguinal hernia but does not prevent direct inguinal hernia from occurring. It is performed in the standing position. And point number 11 is palpation of the testes, epididymis and spermatic cord. The percussion and auscultation findings are: in percussion, a resonant note is present if the content of hernia is intestine, while a dull note is present if the content is omentum. In auscultation, peristalsis may be heard if the content is intestine. The differential diagnosis of a groin swelling is inguinal hernia, femoral hernia, undescended testes, inguinal lymphadenopathy, metastatic deposits, lymphoma, lipoma, hematoma, sebaceous cyst, femoral artery aneurysm, psoas abscess or saphenous varix. The differential diagnosis of scrotal swelling is varicocele, hydrocele, torsion testis, epididymoorchitis or testicular neoplasm. The following modes of investigation are useful in a case of hernia. Number 1 is clinical, the most common form of diagnosis of hernia. Cuff impulse with reducibility of a swelling is usually diagnostic of a hernia. Number 2 is ultrasound imaging. It is useful in a swelling when diagnosis is in doubt, like that of saphenous varix or lipoma of the cord or lymph nodal enlargement. A CT scan may be useful in complex ventral abdominal wall hernias to know the number and size of the defects and associated abdominal pathology. And MRI may be useful in sportsman or Gilmore groin, where the diagnosis is in doubt as pain is the presenting symptom and it is often due to disruption of the inguinal muscles. The primary abdominal wall hernias are inguinal hernias, which might be direct, indirect or combined, femoral hernia, pelvic hernias like obturator, perineal or sciatic hernia, anterior hernias like epigastric, umbilical or Spigelian hernia, and posterior hernias like superior or inferior lumbar triangle hernia. The types of groin hernia are: number 1, depending on the extent, it might be a bubocele, in which the hernia does not come out from the superficial inguinal ring; incomplete hernia, in which the hernia comes out from the superficial inguinal ring but does not reach the base of the scrotum; and it might be complete, in which the hernia reaches base of the scrotum. In this diagram, you can see all the three types of indirect inguinal hernia. In the bubocele type, you can see that the hernia sac does not come out through the external inguinal ring. In the funicular type, you can see that the hernia sac comes out through the external inguinal ring but does not reach the bottom of the scrotum, while in the complete type, the hernia sac reaches the bottom of the scrotum. Number 2, depending on the origin, a hernia might be indirect inguinal hernia which occurs through the deep inguinal ring. It might be a direct inguinal hernia which occurs through the Hesselbach triangle, or it might be femoral hernia which occurs through the femoral ring. Number 3, depending on the contents, it might be an omentocele in which omentum is the content, or it might be an enterocele in which intestine is the content. And depending on the mode of presentation, it might be congenital, in which there are two types. One is congenital vaginal, in which the hernia reaches bottom of the testes, and congenital funicular, in which hernia stops at the top of the testes, or the hernia might be acquired. Depending on the complexity, a hernia is of the following types. Type 1 is occult, which is not detected clinically and only detected by imaging. Type 2 is reducible hernia, which is detected clinically and reduces spontaneously or manually. Type 3 is irreducible hernia, which is detected clinically but which does not reduce spontaneously or manually. Type 4 is incarcerated hernia, which is irreducible and at risk of strangulation. Type 5 is strangulated hernia, which is an acutely painful swelling with ischemia of its content due to the blockade of its arterial supply. And type 6 is infarcted, which occurs when the contents of the hernia become gangrenous. The features of groin hernia are: they are 75% of all hernias, 2/3 are indirect, 1/3 are direct, and femoral hernias constitute less than 3%. Men to women ratio of groin hernia is 25:1. Women to men ratio of femoral hernia is 10:1. The groin hernias occur more commonly on the right side due to the delayed descent of the right testis and the tamponadic effect of the sigmoid colon on the left side. Strangulation can occur in 1 to 2% of groin hernias, while the femoral hernia strangulation rate is up to 20%. The features of indirect inguinal hernia are: it is the most common type of hernia in males as well as females. It is more common in childhood and is often congenital. It is more common on the right side due to the lateral descent of the right testis. The males are affected 25 times more commonly than the females. It constitutes 60 to 65% of all inguinal hernias. It might be bilateral in 10 to 12%, and there is a higher chance of strangulation due to small neck. The features of direct inguinal hernia are: males are commonly affected than the females. It is more common in the elderly. There is no side predilection. It is always acquired due to a weakness of the transversalis fascia. It constitutes 30 to 35% of all inguinal hernias. It might be bilateral in 20% of the cases, and it is less prone to strangulation due to wide neck. The differences between indirect and direct inguinal hernia are: indirect commonly occurs in the young, while direct occur in the elderly. Indirect commonly occurs on the right side, while direct can occur on either side. Indirect hernia can be bilateral in 10 to 12%, while direct hernia might be bilateral in 20%. Indirect hernia is piriform in shape, while a direct hernia is spherical in shape. Indirect hernia is located at the deep inguinal ring, while the direct hernia is located in the Hesselbach triangle. An indirect hernia descends inferiorly, medially, and anteriorly, while a direct hernia projects anteriorly. An indirect hernia is usually reduced manually, while a direct hernia commonly reduces spontaneously. In the three-finger test, an impulse is felt on the index finger in case of an indirect hernia, while the impulse is felt on the middle finger in the case of direct hernia. In the ring invagination test, the impulse is felt on tip of the finger in the indirect hernia, while impulse is felt on pulp of the finger in a direct hernia. In deep ring occlusion test, the impulse is not seen in indirect hernia, while an impulse is seen in the direct hernia. And descent into the scrotum is present in indirect hernia, while it is absent in direct hernia. Location of the sac is anterior and lateral to the spermatic cord in the case of indirect hernia, while it is posterior and medial to the cord in the case of direct hernia. Neck of the sac lies lateral to the inferior epigastric vessels in indirect hernia and medial to the inferior epigastric vessels in the case of direct hernia. The neck of the sac is very narrow in indirect hernia and it is wide in direct hernias. That is why the risk of strangulation is very high in indirect hernia and it is very low in the case of direct hernia. The sac during surgery is opened in the case of indirect hernia, while it is only pushed back in the case of direct hernia. And that is the end of the discussion of part 1 of hernia. If you have any doubts, please put in the comment section below. If you found the contents useful, please like and subscribe to the channel and stay tuned, as next up will be part 2 of hernia, in which we will discuss various treatment options, the use of mesh and laparoscopy in hernia. Thank you for your patient listening and have a nice day.